it's all regarding red flags and why we ask it pretty early on. So red flags determine the setting for our management. So I encourage you all to think about all your patients in this manner, every single consultation. So the first question is, does this patient need to go in a hospital urgently? Okay, so that's all your septic patients, your heart attacks, your strokes, anything that's an emergency, right? So think about that first. Ask those questions first. Rule that out, that you have to make that decision, that clinical management happen. Next, we have, and this is again very relevant to elderly care, consider that this presentation might not be what it seems. It might actually be a hint towards malignancy, and we're getting so much amazing data where, yes, our 2-week wait criteria might say specific things, but thinking about risk factors that patients might have, thinking about other ways that patients might present. So persistent thrombocytosis, what cancers are they associated with? Persistent lymphocytosis, what cancers are those associated with? Again, the more you know about the stuff, the more likely you are to ask about it. But ask yourself, if they don't need to go into hospital immediately, do they have a cancer waiting to be discovered? Do they have something that's urgent referral? Maybe they have, a sudden, features of rheumatoid arthritis. So you might want to refer that to rheumatologists and get them seen ASAP. Maybe it's decompensated heart failure. Maybe it's other, vascular conditions that can really change quite rapidly. So think about those urgent referrals. Ask those questions related to that. And again, it's about those associated conditions with the presenting symptoms. So I love NICE-CKS here, and you'll see all the slides today are from that in terms of our guidelines. Well, majority of them anyway. But essentially, the reason why we're using that, I personally like that as a gold standard, is you've got that background section, it's got that definition section where it tells us exactly when to suspect a condition. But I love that extra little bit where they talk about associated symptoms or what else it could be, differentials. So it's important to think broad and then narrow things down. Okay, that's really, really important. And then lastly, everything else. Right, so if you ruled out that they don't need to go to hospital urgently, they don't fulfill the 2-week wait criteria or urgent referral, then we're managing this in primary care, and how are we going to do that? So I think if you think about every single consultation that way, you're going to be laughing, all right? You'll see this picture on the left has words that are illegible. That's because I use AI to create that picture, and so the spellings are all wrong. But essentially, they relate to these 3 categories over here. So let's talk about the curriculum. I've got this from the RCGP, and this is their super condensed topic guide. So there's the more comprehensive one that you can find on their website as well, just as easily. So it's very important that we're working with patients to promote health in old age. Monitoring, managing long-term conditions and multimorbidity is something that the RCGP like to focus on. Consider the social and psychological impact of long-term disability, declining functions. There is pathophysiology, of course, but there's the normal process of aging we need to pay attention to. And recognizing the difference between the two things is key to getting our patients the best quality of life that we can get them. Again, coordinating care with other organizations and working with healthcare professionals, whether it's acute or chronic, including charities and voluntary sectors. And can I say some of the best resources we have that we can send patients are from charities. So have a look at MS Society, have a look at Crohn's Colitis Society, have a look at ERIC, have a look at Cancer Research UK, which is one of the biggest charities in the UK. So those resources are invaluable and absolutely fantastic. So do think about all of those elements as well. Think about supporting patients, relatives and their carers, and think about disease prevention activities. When we think about older adults, when it comes to things like falls, memory, continence, immunizations, and of course always remember those ethical concepts that are ever so important to giving our patients the dignity of being fairly treated.